To open the next session, please welcome Professor Antonio Villalon, founder of the Medical Oncology Training Program in the Philippines and past president of the Philippine College of Physicians, Philippine Society of Oncology and Philippine Society of Medical Oncology.
Good afternoon. The Andres Soriano Cancer Research Foundation, now known as the Andres Soriano Foundation, implements various milestone projects related to cancer care. In the 1970s, the foundation pioneered the Cancer Research Training and Oncology Fellowship Program in the Philippines, as it encouraged Filipino physicians to engage in cancer research and train them in developing their capabilities for the treatment and management of cancer patients. Today, the Andres Soriano Foundation supported 8 international fellows and over 40 fellows trained locally. Another pioneering effort was the development and implementation of a specialized oncology course and supported the education and training of 22 registered nurses. The foundation was also instrumental in the full renovation of the 50-year-old X-ray and radiotherapy building located at the Philippine General Hospital and converted it into a one-stop shop for cancer treatment and management, now known as the Cancer Institute UBPGH. The Andres Soriano Foundation has set aside a maintenance fund for the various repairs and maintenance activities of the Institute, to which until now is being used. Aside from the infrastructure support, it also provides medical assistance to the indigent cancer patients and continues to support the 5-year maintenance medicine of at least 55 indigent breast cancer patients. Each Andres Soriano Jr. Memorial Cancer Lecture Series is widely known and has been looked forward to by oncology practitioners as it facilitates the bringing in of new technology and knowledge on cancer treatment and management by inviting oncology experts from countries with advanced knowledge on the subject like the US and Europe. To date, over 30 lecture series have been conducted during local and international oncology conferences. This lecture series is dedicated in memory of Mr. Andres Soriano Jr., like his father Andres Soriano, whose life was also claimed by cancer. Mr. Soriano Jr. was chairman and chief executive officer of several large corporations in the Philippines, where he provided dynamic and innovative leadership in the management and development of enterprises engaged in industry, commerce, and cancer. As a person, he was genial and compassionate and showed concern for the welfare of these employees and in his fellow men and championing the cause of social justice. He gave generously to charity and humanitarian projects, sponsored athletic events, and supported the arts. His passing away in March 1984 in Madrid, Spain, at the age of 58 was a great loss, not only to his family, but also to the many companies he managed. On behalf of the Soriano family and the Andres Soriano Foundation, I invite you all to this annual lecture. Thank you.
Good evening, ladies and gentlemen. Our Andres Soriano Foundation lecture is entitled Biomarker-Driven and Molecular Targeted Therapies for Colorectal Cancer. Our distinguished speaker is Dr. Heinz Josef Lenz, Associate Director for Adult Oncology and co-leader of the Gastrointestinal Cancers Program at the USC Norris. He is a professor of medicine and preventive medicine, co-director of the Colorectal Center at the Keck School of Medicine, and the section head of GI Oncology at the University of Southern California. Ladies and gentlemen, please welcome Dr. Heinz Josef Lenz.
It is my great pleasure to talk about today the biomarker-driven molecular target therapies in colorectal cancer. I would like to thank the organizers to give the keynote lecture at the International Conference of the Asian Oncology Society. And I regret that this has to be virtual. I would have loved to meet you in person and discuss a lot of exciting new findings. I think we are living in a brave new world. We have learned incredibly new advancements in the world of colorectal cancer. We are living in the middle of a molecular revolution, understanding more and more activated pathways, identifying novel druggable biomarkers, and we are on the verge to really live a personalized treatment. We have learned a lot about the genetic makeup of colorectal cancer. These are the data from the Human Genome Project, showing all potential gene expression data, protein expression data, methylation data, mutational data, and in order to better understand the composition. And I think in colorectal cancer, we have come a long way to really understand molecular classification as well as predictive and prognostic markers. But you also see that the biggest box in colorectal cancer, seen here in the left upper hand, is the Wnt signaling. And I think this is the key pathway to be successful in the treatment of colorectal cancer in the future. Wnt signaling reflects two major pathways. One is proliferation and the other one is differentiation. And this pathway is altered in over 90% of all colorectal cancer patients. We have still not identified a way to modulate this very critical pathway. We need to inhibit proliferation and we have to push tumors into differentiation. That is the key to cure colorectal cancer. Wnt pathway is, of course, the dominating pathway for colon cancer stem cells, which are ultimately reflecting the resistance to chemotherapy. And you will see many genes which you will become more and more familiar over the next couple of years, such as LRP5 in the membrane, the APC, the axins, the CPP-catenin, the TCFL7-2, as well as ARID1A, because these are new potential biomarkers and drug targets for drug development. But you can see also the box on the right upper part, which is the MAP kinase signaling. We all know that KRAS and NRAS mutations are predictive for the efficacy of EGF receptor inhibitors. We know that BRAF mutant tumors are sensitive to a dual blockage of BRAF signaling and EGF receptor signaling. However, this particular graph also indicates potential molecular escape mechanisms. The choice of first-line chemotherapy is the most important decision you do in order to make an impact on outcome of this patient population. Your choice of first-line treatment will determine the genetic makeup in second-line treatments and the sensitivity for these second-line treatments. You can, for example, see when you inhibit EGF receptor signaling, you may have an outgrowth of subclones from tumor cells who have KRAS mutation, NRAS mutation, BRAF mutation or amplification, upregulation of HER2, upregulation of IGF pathways. But when you use anti-VEGF treatments, this escape is completely different. It could be upregulation of PDGF receptor, interleukin-8, VEGF receptor amplification, and so on. So the choice of your first-line treatment will make different impacts on the genomic makeup of tumors surviving this first line of treatments. So it's very important to understand that the genetic makeup is dynamic and depending on treatment pressure. Identifying a lot of new targeted pathways, of course, is very important that we have potential treatment options for these mutations or activated pathways. And we are witnessing a big development of novel targets and compounds inhibiting small fractions of mutations or activated pathways or fusions. We already know from many clinical trials and clinical data cohorts that when we know the makeup of the tumor and we choose based on the genetic activation of pathways or mutation and prioritize clinical trials based on this genetic information, we change the outcome of patients. We increase response rate, we increase progression-free survival, we increase overall survival. The more we know and the better we make treatment recommendation, the better the patients do. So I want to review with you a few major subsets of colon cancer where we already have witnessed a change in paradigm of treatment of biomarker-driven colorectal cancer therapies. In the New England Journal, we saw that a PD-1 blockage in tumors who have mismatch repair deficiency have dramatic efficacy in refractory patients. And it did not matter if this is a pembrolizumab or nivolumab. We see response rate between 30 and 50%, something we have not seen. I think the biggest incredible surprise with immune checkpoint inhibitors is that we do not see a lot of inherited or acquired resistance. The progression rates in this patient population is between 10 and 30%, but the acquired resistance is much lower. We see extremely long duration of response and extremely long progression-free survival. Now, there is some data in developing that we combine a PD-1 inhibitor with a CTLA-4 inhibitor, so nivolumab and ipilimumab may indicate a little bit higher efficacy, but no side-by-side comparison was ever done, and the use of ipilimumab was limited by the significant GI toxicity, which has been recently resolved with a lower dose schedule, which basically has very little toxicity. We saw at ASCO this year the efficacy of pembrolizumab in first line, and you can see that the progression-free survival in KEYNOTE-177 was significantly longer than the chemotherapy arm. But what is a little bit surprising is that in the first 6 weeks, the immunotherapy curve was below the chemotherapy arm. So we need to be very cautious. Up to 30% have progression of disease, how we select patients. And this raises the question, is pembrolizumab and only inhibition of PD-L1 sufficient, or do we need combinations with immunotherapy, with other target agents, or with other immune modulators such as CTLA-4 inhibitors? But the PFS was very, very overwhelming, with a doubling of the progression-free survival from 8 to 16 months. We presented data on the combination of nivo and low-dose ipilimumab, which actually showed the same toxicity profile than nivolumab alone. And these are first-line data. It was not a randomized clinical trial, with response rate of 69%, 13% a complete clinical response, very few progression of disease. So this raises the question, even a small limited clinical trial, do we need to consider immune combination to increase further the efficacy in first-line treatment? You can see that the progression-free survival and the overall survival was also very impressive. The 2-year progression-free survival is 74%, and the 2-year overall survival is 79%. And you probably are full aware that tumors who are MSI high do very poorly with chemo, as well as very poorly with targeted treatments. So these data are not only much better than we know of, but significantly much better compared to MSI high tumors treated with conventional chemo and targeted combination. The challenge for us is, do we identify patients who really respond very well to immunotherapy despite the high response rate? And many efforts have been initiated and looked at PD-L1 expression, BRAF mutation status, and whether the mismatch repair is a somatic or germline mutation. And you can see on the top, there is no differences, no identification of tumors who would respond better. However, in the lower part, you see that maybe the tumor mutational load, MSI very high, may be doing better with immune checkpoint inhibitors. There are data in small clinical trials showing that a TMB of 40 is a very important predictive marker for efficacy of immune checkpoint. You can also see that some of the tumors which are enrolled in this clinical trial were misclassified and turned out to be, after retesting, that they were not MSI high, but MSS, and these were the tumors who reflected tumor progression. Now, we have other data from other combination treatments with durvalumab and tremelimumab in microsatellite stable tumors, because we know that immunotherapy is usually not very effective in MSS colorectal cancer. But it seems like if there is a high tumor mutational burden in MSS tumors, then we see a significant improvement on overall survival. But I think this effective cutoff level is not established. We see here data for the combination treatment with TMB over 20, but you can see below that there are different cutoff levels done showing a potential benefit, and with cutoff levels of 8 or 10 showing improved survival data in this patient population. Based on data in MSS colorectal cancer in June this year, the FDA approved pembrolizumab for all tumors with a tumor mutational burden of 10 or higher, because based on response rate for this patient population of 29%, 4% complete response rate, and 25% of partial response rate. This FDA approval is now being utilized within the US. I'm not sure in the Asian countries, but I'm sure this data will impact access to patients around the world. So where are we with immunotherapy treatments in MSS colorectal cancer? I think the most impressive data were presented at ASCO 2019 by Dr. Fukuoka from Japan, showing efficacy data of regorafenib and nivolumab. And you can see that they achieved in MSS colorectal cancer response rate in a refractory setting of 36%. That is unheard of. We cannot even reach response rate of 36% in second line of this disease. In gastric cancer, which is known to have response to immune checkpoint inhibitors, the response rate for this combination was 44%. But I think what was even more convincing is that these response rates were also seen in patients who were resistant to the immune checkpoint inhibitors. 3 of these patients were actually pre-treated and responded again, indicating that this combination can overcome initial resistance to immune checkpoint inhibitors. You can see here the spider plot of the efficacy, and which seems to be a very class effect that if you respond or you have stable disease, that seems to last a very long time, to see very few of the blue lines going up, developing progression of disease. We have some 10 to 15% innate resistance, the red lines. But even the green lines, many of these lines go on for a very long time for stabilization of disease, which is completely different than usually targeted or cytotoxic combinations. Another important subgroup is HER2 overexpression. We have seen in the Heracles trial that a combination of trastuzumab and lapatinib, a combination which doesn't include any cytotoxic in HER2 KRAS wild-type patients, resulted in a response rate of 35%. That is again very, very impressive, indicating very smart inhibitory combination of an activated pathway. So when we know what drives the tumor and we have a combination which can successfully inhibit the activation, we see successful tumor response, such in the Heracles trials, indicating that we need to make sure we screen our patients for the HER2 status of amplification or mutations. These data were basically replicated by the My Pathway trial, combining trastuzumab with pertuzumab. And you see again, significant high response rate in this refractory colon cancer patient population, translating into a significant prolongation of progression-free survival. But HER2 is a very unique target, and we have multiple treatment options beyond blocking with an antibody or tyrosine kinase inhibitor. A drug called CW25 is a bispecific antibody which binds to 2 different HER2 epitopes and has shown very convincingly by different binding characteristics, we see significant efficacy in trastuzumab-resistant tumors. You can see here the waterfall plot indicating response rate in multiple tumors, including colorectal, gastroesophageal, breast, and cervical cancers. We know that this antibody can work in trastuzumab-resistant tumors, giving us an additional treatment option. Another exciting development is the antibody conjugate from Daiichi 8201. This binds to the receptor, and it's still not clear what level of expression we need, if really an amplification is necessary or overexpression is enough, and what kind of low expression is sufficient to mediate anti-tumor effect. But this antibody binds to the HER2 receptor and delivers a lethal payload of a cytotoxic, killing the tumor cells. And you can see here that in patients with breast cancer and gastric cancer and others cancer, significant waterfall plots indicating a high efficacy of this very unique antibody conjugate targeting HER2 receptors. So it's absolutely critical to understand the activated pathways, to understand potential subgroups of molecular-defined colorectal cancer which benefit from very unique targeted treatments. I think colorectal cancer is very unique compared to any other solid tumors, because in colorectal cancer, if we have an effective treatment and we can shrink the tumor, we can actually do a curative resections. So choice and identification of highly effective treatment can be the difference between life and death. You can cure a subset if you have a very successful, effective treatment. What do we have learned from colorectal cancer? There are a couple of things which were very unique about this disease. One is tumor heterogeneity. Second is the classification by gene expression signatures called CMS. Single cell classification may be a key for the future to identify a subgroups of cells which are ultimately responsible for the outcome of this patient population. That we now know with dynamics under treatment pressure, these dynamic changes of the genetic makeup allows us to re-challenge with treatments given in earlier lines of treatment. We know that tumor location is not only prognostic, but also predictive. And we have a unique situation where microbiota and the exposure in the gut may play a critical role in the development, but also in tumor progression. So let's start with the molecular classification. I think the researchers in colon cancer have done something very unique. They did not try to take advantage of gene expression signatures just to identify novel prediction and prognostic markers, but to really classify this colon cancer based on activated pathways. Groups which are biologically distinct, opening the window of opportunity to treat and inhibit these activated pathways in these very well-defined subgroups. And when we looked for this classification 1 to 4, we saw in the clinical trial 8045 a randomized phase 3 trial comparing cetuximab versus bevacizumab-based chemotherapy. We saw incredible prognostic impact. Median survival of 15 months in CMS1 versus 40 months in CMS2. Now, CMS1 is the group which has MSI high and BRAF mutations. So what are so unique about these groups? that they are highly prognostic, and can we take advantage of some of these activated pathways for really planning and designing novel clinical trials. What we found out that CMS was not only prognostic, but also predictive. You can see CMS 1 patients did overall very poorly, but there was a significant difference in overall survival compared with of cetuximab versus bevacizumab, almost doubling from 11 to 22 months. This is the first time we identified data linking anti-VEGF treatments with potential immunogenicity of the tumor, which now led to many combination therapies of anti-VEGF strategies and immune checkpoint inhibitors. In CMS2, which is an activated EGF receptor pathway, we saw the longest survival using a cetuximab-based combination with 42 months, 6 months longer than bevacizumab. So we can identify subgroups which benefit from cetuximab, which benefit from bevacizumab, and identify subgroups which may be the basis for novel combination treatments in the future. But we all know that gene expression underlies the big bias of heterogeneity. You can see here in high impact journals, if you biopsy at different sites of the primary tumor or at different sites of metastatic disease, gene expression signature may not be the same. They may be on one side predictive to a certain treatment and the other side of biopsy resistant to a specific treatment. So how do we take advantage or be aware of the challenges of tumor heterogeneity? Our group at USC actually published this data in 2016, showing a completely new insight of molecular makeup of a primary tumor. You can see in the middle a colon cancer gland. And when we dissected this out based on single cell, you can see that almost all cells have a very distinct molecular makeup, very heterogeneous. But based on very complex mathematical models, we were able to identify that the bad cell determining the outcome was already present in the primary tumor. That's a paradigm change, because we always assumed that over time and progression of disease, you acquire some bad features, but it is actually present at the presentation of the diagnosis of colon cancer in the primary tumor. That will have impact on how we treat this patient in the future, because should we do and take out the primary tumor at the time of diagnosis? We just continue to work on the single cell classification of these primary tumors, and were able to publish last year the first data identifying using a signature of different mutations that we were able for the first time to predict if the tumor is metastatic or not, based on the genetics of the primary tumor. You can see on the bottom different signatures of mutations of APC and P53 and KRAS and PTPRT and MRF1 and TCF7L2. Remember, I mentioned that before. These mutations will become very important. This was actually validated in the TCGA and other databases, and we are now trying to take another set of TOSCA to validate the predictive value, because that will shake up how we treat in the adjuvant setting. Do we need 3 months, 6 months, or do we need any treatment at all if we are able to predict metastatic disease? Now, using technologies like single cell classification is very cumbersome and difficult, and I don't think it is prime time for clinical practice use. So how do we use these technologies in our clinical practices? And the answer is liquid biopsies, because the liquid biopsies have the unique advantage. They actually address tumor heterogeneity, because the circulating DNA or circulating tumor cells are a composite of all metastatic sites and do not have the tissue biopsy bias. I think that the circulating DNA is now accepted around the world to really look for molecular escape mechanisms or molecular characteristics of the resistant tumors. But I think the full potential is not really reached yet, because we can also measure gene expression levels, circulating tumor RNA. And the circulating tumor cells as a single cell may give us particular insight into the heterogeneity of cells, identifying the cells which are ultimately responsible for the outcome. Dr. Aparna Parikh at Mass General in Boston did a very elegant study showing patients with GI cancer undergoing liquid biopsies consecutively at her hospital. And at time of progression, she was able to show that in 80% of the patients, she were able to identify the mechanism of resistance. What I found extremely surprising, that in over 36%, there was not one mechanism of resistance, but more than one, median of 3. So checking for KRAS mutation for EGF receptor is not enough, because there may be other mechanisms which will determine your treatment choices. She also did in a subset of these patients a biopsy of the tumor, and was able to show that the liquid biopsy was much more effective to determine the mechanism of resistance than the tumor biopsies. And I think we made a big point about tumor heterogeneity and the bias of the selection of the biopsy site. We all thought and still think that these liquid biopsy would capture gain of mutations and gain of genetic markers, but actually it goes both ways. Under treatment pressure, you can lose certain genetics, including KRAS mutations. This is a small study from Italy showing 10 patients with KRAS mutations treated with FOLFIRI-bevacizumab. And at time of progression, liquid biopsy were repeated, and half of them lost KRAS mutation, and some of these patients were then treated with an EGF receptor inhibitors and had response. So liquid biopsy and the dynamic of molecular changes means gain and loss of genetic characteristics, opening the window of opportunity of treatment selection for unique activation of pathways, but also loss of mutations which would prevent treatments such as KRAS. The timing of the re-challenge with the loss of KRAS mutation is actually well documented. Dr. Pasigin from MD Anderson wrote this very nice article in Annals of Oncology, demonstrating that the half-life of KRAS mutation is 4.4 months. So we know when we change the treatment, and this treatment is effective for KRAS mutant cells, it takes 4 months that KRAS mutation would significantly decrease. This is the basis for clinical trials and re-challenging, because here the Cricket trial was the first who looked for patients treated initially with chemo and cetuximab who had initial response defined by progression-free survival of longer than 6 months, switching treatment to a bevacizumab-based treatment. And look, they need to be on it at least 4 months. That reflects the half-life of KRAS mutations. They were re-challenged with irinotecan cetuximab. And what was shown that you actually were able to identify a response rate of 21%. That's very high in a refractory cancer population like this. Now, I can tell you, if liquid biopsy are applied in this patient population, the response rate goes over 30%. I think we have made a very significant better understanding that primary tumor location is not only a predictive, but also a prognostic marker. Here, we can see the right-sided colon is derived from the midgut and has very unique characteristic. It's actually usually has mutations such as KRAS, PI3 kinase, BRAF, microsatellite instability. The left side is embryologically derived from the endgut. The molecular makeup is completely different. Here you have chromosomal changes, loss of 18q, gain of 20q. And what is very unique about the left colon, it's an upregulation of the HER1, the EGF receptor, and the HER2 pathway, including the ligands of HER1 and HER2. So it becomes very easy to understand when you block EGF receptor for left-sided colon cancers, they are able to overcome this resistance or this pressure with upregulation of HER2, overexpression or amplification. So these are the patients you should monitor particular and focus on the status of HER2, mainly through liquid biopsy, which is the easiest way to detect it. But colon cancer also has a gender effect. We all know that premenopausal women have significantly less colorectal cancer. Here we looked at gene expression levels of males and females, right versus left. And look at this. The differences in male are 148 genes, right versus left. And in females, 2,371. So this makes it very clear females are more complicated, as we already have known. Now we need to, in the future, take advantage of the gender effect and estrogen signaling in order to develop maybe better prevention and treatment regimens. We, for example, know when we give hormone replacement in postmenopausal women, we are able to prevent colorectal cancer. Now, we actually have identified the estrogen signaling in a very unique way. We actually looked, can we treat and target estrogen receptor signaling in the mouse model in using colorectal cancer? And you can very well see that we already have a compound in collaboration with Dr. Stepping and Dr. Chiamas from England that we may have a new treatment option for this patient population. We also know when we put a tumor, a PDX model in a female versus a male mouse, growth is not the same. So estrogen status is impacting not only the development, but also progression of disease. And that is the reason we are so interested in identifying potential new compounds interfering in the estrogen receptor signaling pathway. As you all know, in the colon, we have about 4 to 6 pounds of bacteria. Without them, we would be not able to live and survive. They are absolutely essential. There is significant interaction between this bacteria and the mucosal and the whole body. It modulates immune systems, inflammation, a lot of different pathways, which are all found in the hallmarks of cancer. I want to give you one example. Fusobacteria are the bad ones, indicating significant stimulation of an inflammatory response in the mucosa of the colon, particularly on the right. They actually are interfering with the immune system in a very significant way. We already only thought that they would live on the biofilm on the primary tumor, but they're actually found also within the cancer, very close to colon cancer cells. And what was an incredible breakthrough by Dr. Nuciforo in the Science 2017 paper, he was able to show that these tumor cells who travel to the liver actually carry this bacterium. This bacterium hitchhike, circling tumor cells and settle in the metastatic site. In the colon cancer mouse models, treating these tumors with antibiotics had shown an effect on tumor growth. So we have to learn a lot in the future how we take advantage of the knowledge of what bacteria are involved in the cancer development as well as in the tumor microenvironment. Since this is a keynote lecture, I want to also share some very exciting new data which we generated in our laboratory. We were one of the first groups who identified that patients with Parkinson's disease and potentially other neurodegenerative diseases prevents colorectal cancer. We actually looked at a very unique association of the pathways of signaling associated with Parkinson's, such as the dopamine cycling. And you can see in a simplified way what genes are involved interacting with the different neurons. You can see the different genes of DAT and D1, 2, 3, 4, 5. And we looked, does the genetic makeup or status of these genes predict outcome in colorectal cancer? We used 3 randomized clinical trials, the TRIBE, the Maverick, and FIRE3. And you can clearly see in the genes of DRD1 and SLC that there is a significant association of these SNPs with progression-free survival as well as overall survival. So I think, and tumor response. So indicating for the first time that dopamine signaling is involved in progression of colorectal cancer, not only in the development of it. Opening up opportunities, how can we take advantage of this signaling pathway? Preclinical data already show that when you add dopamine to chemo or target agents in the animal models, you increase potential efficacy. Now you can see that we also not only looked at the germline polymorphism, but gene expression level, and you can see clearly significant association with progression-free survival and overall survival here from the FOLFIRI-cetuximab arm from FIRE3. Completely new insights which potentially impact new prevention and treatment strategies. I want to add and end the presentation with novel approaches, particular on the VAS pathway, because we have not had any effective treatment for KVAS or NVAS mutant tumors. A Cell paper in February 2018 by Dr. Duan showed that VAS mutations are divided in 2 major subgroups, the epithelial phenotype as well as the mesenchymal phenotype. And we have not taken advantage of this. This needs to be a key resources for developing differential treatment strategies for VAS mutant colorectal cancers. We have already learned that KVAS mutations and BVAF mutations are dependent on glycolysis. This is very important because we know we can stop glycolysis with inhibiting the glucose transporter gene with high-dose intravenous vitamin C. Early clinical trials suggest that when you use high-dose vitamin C IV 3 to 4 times a week with a dose of 1 gram per kilogram, you have an anti-tumor effect. It seems to be better and improved when there is an additional mutation in DNA repair. This vitamin C is now in clinical trials available in the US, where we test this for colon as well as pancreas cancer patients. Hopefully, this will be a basis for new combination treatments in the future. At USC, we're working closely with Cardiff Technology and Biotechnology, who found that when in a genome-wide RNA screen, that an inhibitor of polokinase 1 was lethal to VAS mutant cancer cells. This led to a significant development in preclinical models identifying a compound called ovanzatinib, that it has synergism in preclinical model with bevacizumab and irinotecan. Based on this combination, we are now using a clinical trial in second-line FOLFIRI-bevacizumab and ovanzatinib in the clinical trial. The early efficacy data are presented at ESMO this week and showing very promising response rate. I want to make sure, because I still get referral in my office, that non-V600E mutations for BVAF inhibitor clinical trials. We need to know that these mutations outside V600E are doing extremely well, and they actually benefit from EGF receptor inhibitors. They do better than the wild type. So be assured that you confirm what the location of the BRAF mutation is. For V600E, the Beacon trial has been conducted and testing a triplet versus a doublet versus chemotherapy. And initially, these were the survival data from the doublet versus the control and triplet versus control. And it seemed like the triplet has a little bit higher response rate of 26% versus 20%, but maybe that the triplet looked a little bit better. But recent updates at ASCO and ASCO GI, we know now that there is no survival difference between the triplet, which means the BRAF inhibitor in encorafenib, cetuximab, plus minus as a MEK inhibitor, biminitinib. Now, FDA approved the doublet for the treatment of BRAF V600E mutation. This is now also incorporated or has been incorporated in the NCCN guidelines. It was disappointing that the MEK inhibitor did not work, but this elegant data from Dr. Corcoran's lab at Mass General exactly explains why MEK inhibitors are not good enough. You can clearly see using a doublet, a triplet, even using a MEK, it did not really show high efficacy. The only way to shrink these tumors effectively is not using a MEK, but an ERK inhibitor. And you can clearly see the light green. These are the tumor shrinkages and the survival curve. The survival curve is actually doing well. The tumor growth is going down. So I think that this is the new future, in addition to data that maybe BRAF mutant tumor are more immunogenic and combination with immunotherapy are now ongoing. I just wanted to show that we are on the only on the beginning to identify novel targeted and novel trackable treatment options for metastatic colorectal cancer. In 80405, we used NGS in first-line treatment and identified two genes associated with the efficacy of bevacizumab. One is GRM3 and the other one is LRP1B. We are now interrogating and understanding the function and the value of LRP1B. In fact, when you knock it out in the zebrafish, there is no angiogenesis possible, indicating a highly functional mutation which is associated with the efficacy of bevacizumab treatment with a hazard ratio of 0.59. There are also markers, new markers for EGF receptor inhibitors, okay? Here you can see ring finger 43 and ARID1A. ARID1A is a very unique mutation in the SNF complex, which has shown based on our data to potentially benefit from immunotherapy combination with a DNA repair inhibitor. Ring finger 43, very important because this has been also shown to be now a marker of resistance to EGF receptor, and there are already drugs developed inhibiting ring finger 43 mutations, such as an LRP5 inhibitor, which is in ongoing clinical trials in phase 1, sponsored by Boehringer Ingelheim. I want to show you a little bit also new data where we actually see significant interaction with our team science program with Dr. Steve K. group here at USC. You may or may not know that patients who work night shifts, who have sleep deprivation, are at higher risk to develop colorectal cancer. We actually looked at the circadian phenotype of different colon cancer cell lines, and you can clearly see not every cell line undergoes the same circadian rhythm. And this may be responsible for some differences in efficacy of some of our targeted as well as cytotoxic drugs, but indicating that the circadian regulation may become very important. So what we did, we looked at the clock proteins pathways and tested if clock proteins would determine outcome in patients treated in the TRIBE and FIRE3 trial, as well as treated with regorafenib. And we were able to show that different clock proteins predicted outcome with chemotherapy and anti-angiogenic treatment. You see the complex regulation of clock proteins and potential compounds which are agonists of this pathway. But the ability to identify the clock genes as predictive and prognostic is the key for developing potential treatment options in combination with anti-angiogenic treatment. And this is an example of a clock agonist. You can see the different cell lines, and we can kill with the clock protein colon cancer cells, which is incredible, exciting for us. We are now trying to optimize the compounds and understanding the downstream signaling. So we are in a very exciting time on better understanding the molecular genetics of colorectal cancer, identifying subgroups who benefit from very unique targeted treatments, and new association with novel targets, novel activated pathways, opening up opportunities for new treatments. I was also asked to look at the impact of COVID about cancer patients, and there is no doubt that COVID impacted our treatment scenario for our patients with cancer. What do we know about COVID-19? We know that patients with cancer have a worse outcome. They have higher mortality, more visits to the ICU, are more severe and critical ill, and require more invasive ventilators. So you need to watch out and adjust your treatments and how you see and manage the patients in the future. The outcome of patients with COVID and cancer depends on the primary tumor. Hematological diseases and lung cancers are much worse than GI cancer. But GI cancer is worse than breast cancer. So the outcome is determined by the primary tumor, where the lung, of course, and hematological diseases have the worst outcome. But if colon cancer has involvement of lung, the outcome is as bad as lung cancer. So you need to be particularly cautious for patients with involvement of the lungs. The type of treatment is also critical. Patients who are undergoing immunotherapy or surgery are the ones who are at highest risks, who have higher mortality, more visits to the ICU, are more severe and critical ill, and require more ventilation. Chemotherapy and radiation treatment is much less high risk. So I think it's important for us during COVID-19 to strike a balance between risk for patients as well as missing chemotherapy, because we know patients who have symptoms and high tumor burden needs chemotherapy, and that outweighs the risk for potential infections. Because cancer does not wait for corona. I think that cancer represents still an unmet need for all patients to be treated. I hope I could give you a little bit insight in the new and exciting developments of colorectal cancer. I think a German philosopher said it the best. He says, the one who knows more may decide better. We need to make sure that we undergo or recommend extensive molecular testing for all patients diagnosed with colon cancer. I would suggest an NGS panel. I would suggest taking advantage of liquid biopsies, as well as germline testing if there is any young age or family history. I wanted to make sure I actually give all thanks to my whole lab, and this is a reunion at ASCO last year, showing all former and ongoing postdocs from all over the world, from Austria, Switzerland, Italy, Germany, Japan, China, and it has been an incredible experience for me to interact with this incredible, exciting young scientists and physicians, and to establish an international network and incredible collaborations. We have been very lucky to work with many groups around the world to really push science forward, and I couldn't thank them enough because without them, we would not have the success. So I would like to thank you very much for the opportunity to share these new developments and the insights. Why is colorectal cancer so unique? And appreciate your attention, and good luck at this wonderful and inaugural meeting of the Asian Oncology Society. Thank you very much.